Welcome to our second show of Anderson Medicine, where we talk about medicine in Anderson. And this is actually our better show because we've got like the better guy than we had the first show with Dr. Argus. And we've got psychiatrist Dr. Andrew Clafter, who's not only a renowned psychiatrist, but a good friend. And so we'll start with a case like we always do. And this is a case from the news. It's pretty unpleasant. We've recently heard of a West Virginia woman at Cincinnati Children's indicted on charges of felonious assault and endangering children for allegedly putting fecal matter in the IV of her 9-year-old son, causing him to spike a fever. The mother was caught after the hospital taped her filling a syringe with fecal material from a colonoscopy bag and injecting it into the IV. The child has Hirschsprung's, which is a colon disease, a congenital colon disease, and has been undergoing treatment at Cincinnati Children's intermittently since 2011. And so this is a case of Munchausen syndrome. It has a new name, and now it's actually Munchausen by proxy. But I want to introduce our guest, Dr. Andy Clafter, psychiatrist.
Thank you, Steve. Nice to be here. And nice positive note to be introduced on.
Well, so I want to tell a little bit about Dr. Clafter. So he sent over this 3 pages of stuff. I can't read this. This is. But you have like a ton of accolades and just a few backgrounds, and we'll spread some of this in. So you grew up in upstate New York. I would never have known that. Attended college and medical school there. He was a residency at Thomas Jefferson Hospital. He was actually chief resident. That's my plan. I'm only going to have chief residents on this show. Faculty. He's been on faculty at the University of Cincinnati for 15 years. He is the most popular lecturer of the fourth-year students. I'll tell you, he's the most popular lecturer at Mercy Hospital Anderson. I'm always not sure if there's such a crowd there, they're not there for themselves or there to learn. He teaches psychotherapy for the UC residency and is on the faculty of the Cincinnati Center for Psychoanalysis and is also in private practice. So welcome, Dr. Clafter. Our first case is Munchausen, and so what is this?
Okay, so this is let's talk about 2 different syndromes that are recognized: Munchausen syndrome and Munchausen by proxy syndrome. They're related to one another. Munchausen syndrome is when someone deliberately makes him or herself ill in order to be in the sick role and receive the nurturing and support of being a patient in the hospital. So these are people who feign symptoms or actually create symptoms by making themselves ill in order to be treated at the hospital. It's not something that people with a normal imagination would understand. It should sound strange to the ordinary person. Most of us, even doctors, don't really want to be in the hospital when we don't have to be in the hospital. So if someone wants to be there, wants to be getting medical procedures, wants to be getting surgery, wants to be getting lab tests, wants to be getting blood draws, wants to be there, that's highly unusual. It's not something most people would understand. And then the related condition, Munchausen by proxy syndrome, is where typically it would be a parent making a child ill in order to get the child in the hospital to receive medical attention. And again, it's a form of child abuse. It's not something that ordinarily anyone would ever have a temptation to do or understand, so it just sounds like a very strange thing for the general public, as it should.
So this concept of secondary gain. So there's a hidden gain for doing harm to yourself or a family member. Is it fairly obvious what the secondary gain is, or does it take a lot of effort to get at that?
Right. So secondary gain is what we use to describe if someone fakes illness in order to receive medication or receive disability payments or avoid work or avoid military service. If someone, that's malingering, someone lying about being sick, and that's just really lying. Malingering is a fancy word for lying. Primary gain is when someone is receiving an emotional benefit from pretending to be sick. And it's not clear what the primary gain is because it's something that, again, most people don't like to do. If you can think of when someone is ill, do you receive any benefit or support emotionally for being ill? Well, you do a little bit. people feel badly for you. People excuse you from things. People visit you. People care for you. People come by and see you. People nurture you. People support you. Our staff in the hospital are very nice to people. Again, it's not something that most of us with ordinary lives and people in our lives need to do for emotional support, but this is a way that some people actually, and it's a very rare condition, by the way, very rare. So it's not something that ordinarily you will ever encounter in your life unless you work in a hospital. Then you do see this once in a while. So it's receiving kind of the nurturing and support of being in a sick role. It also gives people sort of an identity. Some people become like a professional patient in a way, and they're known for suffering a lot from some condition, and they come in the hospital and people know them. So it gives people a sense of nurturing, a sense of identity, a sense of being cared for. Now, when you talk about this being perpetrated on one's child, it's somewhat different. It seems to me from the experiences that I've had meeting people with this condition and also reading about the disorder that some parents actually get a sense of identity, like I'm now a devoted, selfless parent with a sick child that I'm an advocate for, and it takes on like a sense of identity in the person's life. And that's what seems to be the motivation. Again, it's something that is not what an ordinary person with an ordinary imagination would ever wish to do or would ever be tempted to do. So it's a very hard condition to understand. The other thing is it's a very lethal disorder. I mean, a significant number of children whose parents do this to them can die or get real illness. So it's something that has to be treated very seriously, and the legal system is always involved when there's a suspicion of this case. So Children's Hospital, if that's where, I mean, I only know about this from hearing it from you right now, but Children's Hospital is certainly very highly equipped to detect parents who are faking illness in their children and will alert the authorities as well as child advocacy programs, and they're very responsible about it.
So how's this different from hypochondriasis, which is fairly common?
Hypochondriasis is a person who's very worried about being sick. Like, I'm afraid that I have a heart condition. And when I feel myself getting sweaty or an ache here or short of breath, I'm afraid, gee, is my heart not doing well? And I'll want to go see my doctor, and I'll want to see a cardiologist. I'll want to stress tests. I want pulmonary function tests. I want to make sure that my blood pressure is okay. And I just can't be reassured that I'm fine. You know, that the reason I'm out of breath is because I just climbed 5 flights of stairs, and it's normal to be out of breath. So I'll get reassurance, and then I'll worry again. It's worrying a lot about having illness and trying to get reassured that everything's okay, but being very worried about getting illness. It's not someone that is pretending to be sick. It's someone that's very afraid of being seriously sick, and they're seeking reassurance all the time to make sure that they're not sick.
So it's kind of a form of anxiety, the same as anxiety? Is it a subset of anxiety? Because anxiety makes everything worse. And just kind of like throws kerosene to the flame, it seems like.
It is an anxiety disorder. It's a lot like obsessive compulsive disorder about your body and about your health. It's like you just can't stop worrying about possibly being sick.
So you're, I think, most famous grand rounds, I wrote this down, the healthy patients who think they are sick. Which, you know, like how much of your day is pretty much that?
Healthy patients who think they're sick? Not a lot, really. People don't get admitted to the hospital nowadays unless they're pretty sick. So the people that I see in the hospital have legitimate illness and are there getting treatment for illness, and it's actually not a big part of my day. People with hypochondriasis, you wouldn't see them in the hospital. You would see them in the outpatient setting. And typically, they're not interested in seeing a psychiatrist. They're interested in seeing their primary care physicians or specialists to make sure that they're not very ill. And after, you know, the primary care physician says, gee, this man or woman seems very worried about being ill all the time, then they might make a referral to a psychiatrist, but it would be on an outpatient basis. But in the hospital, no hypochondriasis.
So one of the things that we didn't mention in your long thing is that you are the consultative service for the inpatients at Mercy Hospital Anderson.
Right.
So what's the difference between consultative psychiatry and getting admitted to a psychiatric unit? Are they the same? Are they? What?
It's different. A consultation service is when people who are in the hospital getting medical or surgical care need a psychiatric evaluation, and that could be for any number of reasons. It could be because someone is just suffering from anxiety or depression while they're in the hospital being treated for pneumonia or any other condition. And so while they're there, they would benefit from a psychiatric evaluation and recommendations for treatment. There might be people in the hospital who are having side effects to their medical treatment, or people who are having psychiatric symptoms caused by their illness. A common thing in the hospital is people who are ill with an infection or receiving a lot of pain medication can become very confused, what we call a delirium, and so that sometimes requires a psychiatric assessment. We have people in the hospital who are there because they've attempted suicide and they're being treated for what they've done to themselves, and so they need a psychiatric assessment to make sure that there's a safety plan in place. Those people might require a psychiatric hospitalization when they're done with their medical treatment. A psychiatric hospitalization is someone who's not being admitted for medical or surgical treatment. They're being admitted for psychiatric illness, which is too severe and unstable to be treated in the outpatient setting. So it's a safe setting where people can be treated aggressively for a psychiatric emergency. So that includes people who are suicidal, people who are hearing things or believe things that are not true, that are suffering from what we call psychosis, and people who are a danger to themselves or others. That's what an inpatient psychiatric unit is for, or just very severe illness that can't be managed easily in the outpatient setting.
So there's the overlap between inpatient consultative psych and neurology. In fact, the boards of the psychiatry and neurology, they actually overlap, you know, the neurologic, Parkinson's and whatnot. I mean, is there a lot of stuff that you end up, it's really neurology it's really psychiatry, back and forth, or is it pretty clear?
Well, there are some things that are very clear that they're one and not the other. All psychiatrists have to do training in neurology as well as part of their residency training, and all neurologists have to rotate through psychiatry as part of their residency training. And you're right, we have the same board that credentials are, you know, it's the American Board of Psychiatry and Neurology. There are some conditions that there is an overlap. There are conditions where people have what we call a neuropsychiatric disorder, where, you know, the brain and the mind are, I mean, that's the idea is that psychiatrists are treating the mind, neurologists are treating the brain. That was originally the idea. But we know that the mind is a function of the brain. So there are certainly some conditions where both a neurologist and a psychiatrist are needed, but it's pretty distinct. It's pretty distinct. Sometimes the diagnosis is not clear. There are people that come into the hospital and they're very confused and they're not communicating clearly, and it's not clear whether they're suffering from a severe psychiatric condition or whether they're suffering from a neurologic condition. And then we'll typically have both a psychiatrist and neurologist on the case. For some reason, usually the neurologist says, "Oh, this is psychiatric,"
right,
and I
yeah.
say, "No, this is neurologic." But there is absolutely overlap between our fields.
Yeah, we see that a lot. So just sort of the final question about our case, Munchausen. It's we're actually moving away from calling diseases by somebody's name to something else, like what the disease is. So it's
factitious disorder.
Right. So so
Right.
the new diagnosis, factitious disorder on someone else is factitious disorder by proxy. How often have you seen this? I mean, it's a pretty rare thing.
It's a rare thing, but because I'm a consultation psychiatrist in a community hospital, I think I've probably seen approximately a dozen cases of Munchausen or factitious disorder over the years.
And so that's actually
the last decade.
That's actually a pretty big number. I mean, you think there's a research project there?
I think there might be a research project there.
In fact, I think your co-collaborator is a really famous physician here in town.
Yes.
It would be me, and I actually owe you a bunch of stuff, I think.
Right. So we're going to try to look together at a case series of people admitted to our hospital. We're going to wonder how many times were they admitted to the hospital before there was a suspicion, who first detected it. I think it's actually the nurses that know better than doctors when this is happening. Usually the nurses are the first to pick this up. How long does it take? What kinds of illness do people perpetrate on themselves? And are there also signs that there are motivations to get pain medication or be in disability? Is it both primary and secondary gain or only the emotional gain? That's what we'll try to look at together.
Yeah, and that actually came up. One of the things that we do is that someone sort of identified like this, when they come in, they get the same doctor, they get the same unit, almost the same nurse, so that there's consistency, because the stories are just so compelling that, you know, if you don't kind of have that history, even though you can read it, it's good to have that continuity. We'll pause and say, if you're just joining us, it's Anderson Medicine. Our guest today is psychiatrist Dr. Andrew Clafter, consultative psychiatry. We'll move on for your private practice. So in addition to consultative psychiatry, you have a private practice. Do you have a couch?
I do have a couch.
Does the couch like something that in fact, I should be laying on the couch and you should be like talking to me.
That's for your third show.
Oh, okay, that's great. So what do you do in private practice?
Well, I'm a general psychiatrist, so I treat people who are suffering from psychiatric disorders, adolescents and adults, and the most common conditions are anxiety disorders and mood disorders. I do have a subspecialty, which is psychoanalysis, so I treat people who are suffering from really complex disorders that have not responded to the first-line, shorter-term interventions, or which have not responded well to medication. People that need an intensive form of psychotherapy, which is what psychoanalysis is. So that's, psychoanalysis does not necessarily make use of a couch, but often makes use of a couch. It's a technique to help foster relaxation during the treatment setting.
So like laying there not looking at you is actually what Freud did, but I mean,
well, it's interesting. Freud wrote about using the couch. Freud felt uncomfortable having patients look at him. So he innovated the couch in order to not be looked at by his patients. But we discovered that actually we think that there's a benefit for people with certain kinds of difficulties. Having the person just attend to their own thoughts without any distractions from a person looking and nodding is a technique that we use called free association. So the couch is helpful for free association. It's not an essential part of the treatment. It's often used. And it's sort of a tradition in psychoanalytic psychotherapies.
So is there a certain kind of stigma with having to go see a psychiatrist? Or I know that your waiting room is designed so that really just one person, so you don't like go in and sit next to your friend that you're finding out that is coming to see you.
Right. I have a separate exit,
Yeah.
so that people that leave don't go through the same waiting room. Well, there is a stigma still in our country with any forms of mental illness. It's culturally based. There are some areas of the country, like the Northeast, where there may be a stigma with not going to see a psychiatrist. But yeah, I think that there still is a stigma with mental illness. I think the idea that someone requires emotional support or is not doing well based on mental or emotional difficulty makes many people feel like it's a form of weakness and something that they're ashamed of. And so we unfortunately still do have a stigma. The design of my office is really for confidentiality more than for stigma. You know, that I think that it's important for people to have confidential access to psychiatric treatment. And so one of the ways that people would know that you're in treatment is running into someone in the waiting room. And, you know, it's a small world,
Yeah.
so eventually, you know, you might run into your next door neighbor in a waiting room if it's not designed in a certain way. So that's why a lot of psychiatrists design their waiting rooms in this way.
So what is the no-show rate for like new appointments? Is it really high, or is it people have been really waiting to get, because there's a huge demand, for behavioral health, mental health?
For me, the no-show rate is incredibly low. Like, I can't remember the last time someone did not show up for a new appointment. It's also a feature of your practice. The people that I see have typically been seen by at least one or two psychiatrists and multiple therapists before, so they're highly motivated to get help. So I don't have a high no-show rate. There are other settings where there's a very high no-show rate also, but I'm fortunate in that way.
So one thing we also didn't mention is you're a faculty member of the Cincinnati Center for Psychoanalysis, and sort of what's the difference between psychotherapy and psychoanalysis? We were just looking up. There's 30 centers for psychoanalysis around the country.
That sounds
one in Cincinnati.
Right. There's one. There's 30 some odd. I don't know the exact number. I'm hearing that from you, and I believe you. But the American Psychoanalytic Association has a network of centers throughout the country, and we're fortunate to have one in Cincinnati. That's a big reason why I settled here, actually, is to train as a psychoanalyst while I was working at the university. That's one of the things that drew me to Cincinnati. So psychotherapy is treatment for emotional difficulties through talk therapy. That's what psychotherapy is. There are many different forms of psychotherapies. Some of them involve things that have to do with also exercise and the body, or hypnosis, or deep relaxation. Some are a form of behavioral training. Some are cognitive therapies. One form of psychotherapies are psychoanalytic therapies, which involve thinking about emotional problems as being due to conflicts that people are unaware of, or conflicts going on in the person's unconscious. That's the term we use for the area of the mind that people are not aware of. So psychoanalytic therapies are therapies designed to help people who are suffering from emotional difficulties that require attention to that area of your mind that you wouldn't ordinarily be attuned to or think about. And those therapies involve meeting people frequently for an intense amount of time, and they're reserved for conditions where a shorter and less frequent treatment won't work. So most people that have psychoanalytic therapy have typically tried other forms of therapies that would be briefer and less frequent first, and they haven't been able to get good results.
So one of the things that I've always heard about psychoanalysis is you need three things. You need time, money, and a problem, kind of in that order. I mean, it's tremendous. It's like, is it like every day of the week? How frequent are the sessions?
Well, psychoanalytic therapies are 2, 3, or 4 times a week, typically. That would be the frequently. So 2, 3, or 4 times a week. Psychoanalytic therapy can be very expensive. Some people's insurance companies do pay for their psychoanalytic treatment, or a significant amount of it. We have a treatment grant at the Psychoanalytic Institute, which subsidizes treatments for people who can't afford to pay full private fees for psychoanalytic therapy. And most psychoanalysts, to have the privilege to work with someone that closely, will substantially reduce their fees for people that are coming multiple times a week. It would be a much lower fee than people that are coming once a week or less. So it's subsidized or fee reduced for the most part. There are very few people that could afford to pay the full fee and come 3 or 4 times a week. I mean, that would only be the very wealthy. And we don't want this treatment to be limited to people who are very wealthy.
So you're faculty, which means you train residents, other psychiatrists. Who's part of the training as the institute?
So the people that get training at our institute, we have a number of training programs in psychotherapy, advanced psychotherapies, and in psychoanalysis. And they're mental health professionals. So they're psychiatrists, psychologists, licensed clinical social workers, and licensed counselors.
So just kind of changing subject, it seems to me that what you do is part legal. You're almost like a lawyer in many cases. In fact, you're an expert witness frequently. How often is it really not a psychiatric issue, it's a simple legal issue? And one of those questions is we're trying to determine whether someone has the capacity to give consent and those things.
Right, so in the hospital, this is especially true. In the hospital, sometimes people need to make medical decisions, and because they're sedated by medications or because they're impaired just due to the underlying medical illness they're suffering from, they're not able to really clearly answer questions about what their preferences are or what they wish to do. Like, there are different options available, different types of surgeries, different types of medications. And so in those cases where it's clear, there would be a relative usually who's making decisions based on what they believe the person's best interests and wishes would be. Sometimes it's not clear, it's a judgment call. Like, is this person able to make decisions or not? We believe very firmly, it's a basic principle of our medical care system, that we cannot administer medical care against someone's consent. So if someone is declining surgery or treatment, even if we believe it's very important for them to get it, we have a legal and moral obligation to not force treatment on someone. But that's only if that person is making really sound decision based on their best judgment. So when we have cases in the hospital where it feels like it's not clear to us, does this person really understand what he or she is deciding to do? So I think that's what you're referring to, that I may be consulted to give my opinion as to whether this person seems to be able to make decisions that are sound based on a good knowledge of the information balanced reasoning, rational decision making. So that's part of psychiatric training, is to be able to make that judgment call. And then that will sometimes be used in court as testimony.
So you ever been somewhere where there's an announcement overhead, is there a psychiatrist in the house, where you had to, because every once in a while, you get that dreaded thing on the plane, is there a doctor? And
Right, is there a doctor on the plane? I don't answer yes to that one anymore if there's a doctor on the plane. I might say, well, I'm a psychiatrist and no one will want my assistance with anything. No, I've never had that overhead, is there a psychiatrist?
Huh. So all hospitals have the same code system, and it's based on colors, and code blue is the acute life thing, code pink is a neonatal.
You're giving away our secrets, Dr. Fagan.
It's on the badge.
Okay.
So, and so there's a code violet. And code violent is a person who is violent. And violence against healthcare workers is increased. And one of the things I really learned from you is dealing with people whose coping mechanism is anger, angry people. And so do you have any kind of comments on, because in many cases that's who you see, is somebody who's just angry.
Right. Well, what we try to do in mental health, if someone is very angry, we try to convey to the person, well, first of all, we have to establish safety. So if there's not physical safety, it kind of doesn't matter what the reason is. We have to establish physical safety. And we have a very good staff at Anderson Hospital that are very professional and good at doing that. Usually before I've arrived, safety's already been established. So what we're trained to do is to try to be as interested as possible in what's making someone angry. That's a lot easier to do when safety's been established. Someone might be reacting to something and the reaction seems very, very unreasonable, but if we can actually find out what is really provoking this reaction, number one, the anger starts to seem more reasonable. We can understand why someone's angry. And number two, the person who's angry feels less angry because someone is actually listening now to what is so distressing. So that's the major, I know it sounds simple, but that's not as easy to do as it sounds. And that's really one of the major ways that we intervene with people who are having a huge angry emotional reaction in the medical setting.
Well, Andy, I've actually learned so much from you, and thanks for being on.
Thank you for having me.
In the news this week, I wanted to talk about the passing of a local icon, Sister Ruth Nasthold, who passed away at the age of 84 a week ago. She was a Sister of Mercy for 64 years. She was a fixture. She actually retired in May of 2013. The medical staff awarded her a Doctor of Letters, effectively making her like Sister Ruth. She was at Our Lady of Mercy Hospital in Marymount since 1975, came over when the hospital was built here in 1984, and served on a ton of boards, including the Springfield board where I came from. You may know Sister Ruth lived in that house that was on campus. Her and Sister Carol Ann lived there for like 20 years until she moved after retirement. And so, Sister Ruth. Next week, we're thinking about sports. Baseball spring training starts today. And so our guest next week will be sports medicine, talking about concussions with Lisa Sweeterman, Director of Sports Medicine for Mercy, and Rocky Tacolvi, the Program Manager. And so thanks again for a week of Anderson Medicine.